Hello. Good afternoon. If I can have everybody's attention, I think we should start the proceedings. Welcome to the 2014 Fiji Pharmaceutical Society Annual Conference. And first off, I would like to ask our President, Mr. Avnil Narayan, to deliver his welcome address. Thank you. Thank you, Rina. How's everyone doing today? Good. Okay, it gives me great pleasure to welcome you all to the 2014 Fiji Pharmaceutical Society Annual Conference. I hope more people would have turned up on time, but nevertheless we start with this number. Yeah, of course. So the theme for this year was chosen as promoting safe use and access to medicines. And I hope by the end of this conference, we will all take new knowledge to enhance our role in promoting medication safety. Also like to acknowledge the presence of our two international speakers, Mr. John Jackson and Dr. Narita Smith here, who bring in their wealth of experience to impart their knowledge to us and help us better our practice. The organizing committee this year has put up a great program that is intellectually motivating, and I hope it encourages us pharmacists to be more vigilant. And also the conference is a time not just for attending sessions, but also to meet and mingle with everyone. So I encourage all of you to take time out and meet new friends and old colleagues, catch up on things, and I hope all of you have a great time here. And also, finally, I'd like to thank all of our sponsors that have made it possible for us to have the event catered for and done here at InterContinental. So thank you, sponsors. And I hope all the participants here who are already here and yet to come have a great time during the conference. Thank you. Thank you, Avnil. Now I'd like to invite our first speaker for the evening, Mr. John Jackson, who hails all the way from Melbourne. Mr. John Jackson, your floor is yours.
Thank you. Good afternoon. It's a great pleasure to be here. I would like to bring the good tidings from the Western Pacific Pharmaceutical Forum to the Fiji Pharmaceutical Society. And I'd like to thank Shanil for the invitation to speak. It's a great honour. I have been asked to speak on a couple of occasions, and what I hope you understand from the presentations that I make is a lot more about the International Pharmaceutical Federation and the Western Pacific Pharmaceutical Forum. We're going to do this one. Yep. And the first of the presentations is about pharmaceutical policies. Talking about policies can be a rather dry topic, but it is an important topic, as hopefully you will see through this presentation. And I thought it might make it slightly more interesting if I actually present a case study, and I will be talking about the development of community pharmacy in Australia to illustrate the impact of policies. The focus that I will use is that of the President of the Western Pacific Pharmaceutical Forum, giving me an international focus, but also bring to bear my understanding from a domestic focus as a result of me having been heavily involved in development of policy at a governmental and professional level in Australia. And I've got on the slide there the lecture outline that I hope to move through during the next 50 minutes or so. So why do we need policies in relation to medicines? Well, We all know medicines are not an item of normal commerce. I mean, if that was the case, we would have no role. But people do not understand what medicines they need. They do not have the capacity to tell whether a medicine is of an appropriate quality. And we know the stories of people inappropriately using medicine. But it's more complex than that. We know of the problems of falsely labelled, spurious medicines. And so there is, unfortunately, a huge risk associated with medicines, a clinical and financial risk, as a result of people actually purposefully falsifying products. You cannot rely upon the global market to regulate this and to ensure people get the benefits they need from their medicines. It just does not work. We actually need to establish policies and regulations to help people get the benefits that they need from medicines. And we as pharmacists work in probably one of the most regulated environments of any profession. And on this slide I've actually illustrated just two areas of regulation, all of which is covered by policy. The top line relates to the product itself, and as you know, ostensibly, the manufacturing facilities, the products themselves, the distribution processes, the advertising of medicines, it's all heavily regulated. Policy abounds. And down on the bottom line, the practitioners and the processes they use and the funding, also heavily regulated. So we work in this space of heavy regulation, but in fact I'm looking at it through a slightly different lens. I'm going to look from a global perspective to start with, global health regulation. Step down to medicine regulation at a global level and move down through national regulation of medicines that start to have a bearing on us as pharmacists, and eventually look at how our practice and our role at improving the use of medicines is impacted by that hierarchy of policy. And it's not always going to be the way we would expect. There are going to be occasions when some of the regulation that applies, particularly in relation to financing of medicines, may well have an impact on our capacity to deliver rational use of medicines, an impact that we did not expect to see. So what I will do is use a slide to illustrate and describe each of those areas of regulation, starting at the global level of universal health coverage, a policy introduced by WHO, and they're very serious about promoting universal health coverage at the moment. They actually did promulgate the policy over 10 years ago, but it's been laid dormant, but they are now pushing it quite seriously. It's not a new concept, it's just the concept that people in the community, in a socially aware community, do need some protection and assistance to gain their access to the medicines they need. And there are three arms to it. Over on this side, you see it's got an arm that says more people should have access to healthcare than is often the case. On the other side is an arm that says the healthcare that they have access to should be broader than what is historically the case. Yes, they might have access to see a doctor, but do they actually have access to the medicines, or does the doctor have access to be able to prescribe the medicines? So more people have access to a broader range of healthcare, and this has to be done in a way that is affordable to the individual. So they're the three arms of universal health coverage. That's a very, very difficult problem, and it doesn't matter what country you're in. That is going to be hard to achieve. Now, that's a policy at a global level, and it's about healthcare in general. It's not specifically about medicine. But if we stay at the global level for a second, we could look at another WHO policy, and that is the policy in relation to access to essential medicines. So here we've picked up a global policy that relates very specifically to medicines. And in this policy, there are a number of things addressed. It argues for the need on the lower, well, I'll start at the top. We'll start at the lower right as you're looking at it. The quality of the product. It's almost a given that there is a need to regulate quality of product, because if it's not regulated, there is great risk in it actually not being of an adequate quality. There needs to be adequate funding in the system for appropriate quality products to be distributed. Down here on the bottom left, the price that people pay for those medicines has to be affordable within the economy of the people in that community. And up the top left, there's got to be appropriate choices around which medicines are used, who is prescribing what medicines for people. So these are the four components of a policy relating to access to essential medicines that WHO is promoting at this stage. And again, this is a level of policy that has a global relevance, but it also starts to have direct relevance to individual countries. And that's where I'd like to move now. The next step down in that hierarchy of policies was the concept of a national medicines policy. Again, this was promulgated by the World Health Organization back in the 1980s, late 70s and 80s, at about the same time they started to promulgate essential drugs lists. But WHO did not develop a national medicines policy because this has to be country specific. All WHO did was create the concept and the parameters of what should be covered. They didn't develop a policy themselves because, as I said, this has to be country specific. But not all countries have elected to do so. You go to the United States, there is no national medicines policy, but there is in countries like Australia, and I've read the documents that you have here. What we find in those documents, in accordance with FIP's, the WHO recommendations, is a long list of areas of practice and behaviour that could be regulated through policy. And which of those get covered in any particular country's national medicines policy depends upon the health system in that country. Malaysia has just recently rewritten its national medicines policy. The policy it had previously included sections on the health workforce because till that point they were still in the phase of needing to strengthen their health workforce, build capacity and capability. Seeing they've actually focused on that for some 10 odd years, the rewritten national medicines policy in Malaysia has been able to drop that as an aspect of their policy. And I say that to illustrate how a national medicines policy really has to be developed specific for each country's circumstance. The schematic representation here is of Australia's national medicines policy. We developed this in 2000, and sitting in the centre of the circle is the healthy consumer. That is the goal of the national medicines policy. And sitting around that in the yellow is the quality use of medicines. I should say that Australia's national medicines policy only has 4 areas in it. It doesn't have all these, it just has 4 because it's been able to be developed specific to the requirements of the Australian community. And coming back to this side again, in the centre is the healthy patient as the focus. Around that is the quality use of medicines. So it's actually at the point of use that you get closest to the patient. Around that use of the medication, the yellow section, are 3 other sections. Top left in the blue is the quality of the product. The quality, safety and efficacy of the product. If you don't have good quality product, you will not get good quality use of medicines, you won't get a healthy patient. Over on the right, top right, in the red, is equity of access. That means that people have to be able to gain access to medicines of appropriate quality and for them to be used in the appropriate manner. So you can see how these components of the Australian National Medicines Policy have been built up, and it's a good illustration of how a global concept promulgated by the World Health Organization has been made applicable at a local level. And I come down to the last level of policy consideration, and that is how does it affect me as a pharmacist in my practice, be it a hospital or community or wherever. And I've illustrated that here by showing that things eventually come down to the good pharmacy practice guidelines. It's a policy, a set of guidelines developed by the International Pharmaceutical Federation and endorsed by the World Health Organization. And over on the right, there's a long list of the various things that are covered by those guidelines. And I can show you bit by bit how the concept of universal health coverage, equity of access to medicines, the principles of national medicines policy and good pharmacy practice come down from a global all of health concept down through global medicines concepts, all the way down to the point where I, as a pharmacist, am practicing and how I should practice according to good pharmacy practice. So they're the principles of health policy and how they work, and they are generally being implemented. Underlying all that is making sure that people can afford the medicines or the healthcare they need, and a cornerstone of that is having some form of universal health insurance for the population, whether that is run by the government or whether it's run by private insurance companies. And most countries in this region are trying to develop such policies and such health insurance programs. But it's hard because eventually the cost to the insurer becomes quite burdensome because of new drugs, increased use of drugs, and more expensive drugs needing to be covered by the policy. There is also that concept shown on the second point here that as drugs become more affordable to people, there is the risk that they will actually use more drugs, perhaps beyond what they actually need. So there's that concept, the economist's concept of moral hazard in making things like healthcare cheap to people. So all countries struggle with the task of including medicines in their national health insurance policies. So what do they do in response? The insurance company, and it doesn't matter whether it's the national insurance company as is run by the government in Australia, our Pharmaceutical Benefit Scheme, or if it's in the United States, the private insurance companies. It doesn't matter where it is, they all start applying the same principles of limiting the amount that they will cover, either by restricting the number of drugs, or only funding at the cheapest drug, or making the individual pay a greater proportion of the cost of medication. And I've got a long list there of steps that the insurance companies start to apply to their cost burden of offering offering insurance against the cost of medicines. So, what does that mean for me as a pharmacist? Well, you know, it's 25 years ago that Heckler and Strand, the two American pharmacists, came up with the philosophy of pharmaceutical care. And underlying that is that we should change the focus of our practice from supplying a product to ensuring the best health outcomes for the patient through the use of that medicine. Some significant strides have been made in those 25 years to help us do those things, but unfortunately a lot of the profession is still focused on the supply of that product. If we are commercially dependent upon the supply of that product, and that's the sole source of our income, as is often the case in a lot of countries around the world in community pharmacy, then all those principles that I had on the previous slide of how insurance companies will behave as medicines become more comprehensively covered by insurance, all of those policies will mean that our insurance coverage will be tightened. Now, it is fantastic that the community have more access to healthcare and the costs are being offset for them. But what it means for us as pharmacists is we will face a limited amount of funding. We will see a reduction in the amount that we are remunerated per item dispensed. And this has become a global development. We need to make sure that we actually build our practice in a way that sees revenue into our pharmacy services not being solely tied to the supply of the product. And this is where that feedback loop in that hierarchy of policies comes into play. I won't go back to the slide, but you will recollect I showed that if you come down from universal health coverage all the way down to the national medicines policy, the funding of medicines, that there was a red feedback loop around the rational use. And if the sole source of income for a pharmacy is in fact, and particularly a community pharmacy, the supply of medicines, their capacity, that pharmacist's capacity to continue to provide a broader range of professional services will be limited unless we can broaden our revenue base. And that's illustrated here. Historically, we received nothing other than remuneration for supply. And at the moment, in some countries, there's a bit of remuneration for professional services not linked to supply. We've fought long and hard to try to build that base. And there's a lot in the global literature of how to do that. But eventually, we're actually going to have to get to a point where the revenue from dispensing, the dark blue, is a much smaller part of our revenue than the revenue from than is the case now, and we are going to have to build a much more significant revenue source from our professional services. When you tell this to a lot of governments, they just don't understand. But we run commercial practices in running community pharmacies, and the reality is the current structure of health policy, trying to protect the public from the cost of pharmaceuticals, will see the insurance company, be it the government-run insurance or otherwise, applying pressure on our revenue base, which will make it very difficult for us. I now want to step to the case study, Australia, and I could be very brief. I could say these issues are playing out in Australia right at the moment. But what I want to do is actually show you how there is an opportunity to build a professional service-based practice and all the steps that are being taken in Australia, and hopefully this will give you some ideas for what you might be able to think about introducing here. They're the steps I'll go through in this next the remaining time, and what we do know is that healthcare is incredibly expensive, as I've already said. This is Australia. We spend about 9% of our gross domestic product on health. It is our largest industry. You see the big yellow bar is the United States. 18% of their gross domestic product is spent on health. It staggers me that they can spend, almost twice as much as Australia does, and yet the health status of their public is actually worse than in Australia. Our average life expectancy, our infant mortality rates are all better in Australia. They're better in Korea, they're better in Canada than they are in the United States. So spending more doesn't necessarily give you the answer. What I have over here, Fiji, which I understand has about 4% GDP expenditure on health, which is not dissimilar to what a lot of other economies similar to Fiji spend on health at the moment. So the question is, how do you actually get best value out of whatever you've got available to spend on health? In Australia, that risk of moving up from the 9% higher and higher is troublesome. We have a population that's getting older, people living longer with more chronic disease, using more medicine, needing more health care, and the government's projected that we'll be spending a lot more of our GDP on health, unless we can do something about it. And we had a significant range of reviews and studies undertaken. And what I've got on this on the next slide are 10 points, which I think are a summary of all of the reviews. And having had the opportunity to spend time in a number of countries of similar nature, similar health service to Australia, I could be saying exactly the same if I was in Canada or in New Zealand. These are universal issues. That the tertiary hospitals that we run are too expensive. We spend a disproportionate amount of our healthcare dollars in the expensive tertiary hospitals. We have to work out how to make them more efficient, save some of the money expended in tertiary hospitals and move it into the ambulatory care area, because that is so much more economic as a way of caring for people. We've got to integrate the services provided by different components of the health sector and focus all that care around the patient. So rather than it being a doctor-centric or a pharmacist-centric health system, it's a patient-centric system with integration between the healthcare providers. At point 5, this starts to really create great opportunity for pharmacists. There needs to be more entry points in the health system. Because at the moment, most people enter the health system through their general practitioner. And it's like a funnel. It's a blockage point. And that creates inefficiencies, and inefficiencies create expense. So the pharmacy can step forward, particularly community pharmacy, and say, we can be an extra entry point into the health system, and we can. Then that's great for the health system, but it's great for us as pharmacists. All communities and societies, including Australia, have people who have lesser health care and quality of care than others. In Australia, our Aboriginal people and some of the people in the remote and rural communities have lesser health outcomes, and we need to focus extra health expenditure in those spaces. Continuing with the last few, we've got to address inefficiencies that arise as a result of the poor use of the skills of healthcare workers. No longer can we say that, well, a doctor's the one who historically has done that work and so they're the only ones who can do it, if nurses or pharmacists have the skills necessary to do a particular task. We've got to create efficiencies through the use of technology and communication technologies and information. We've got to start conducting preventative health programs and maintain good health. All of those points are positive for this profession of ours. In Australia, you need to understand a little bit about the health structure in Australia if I'm going to talk about the way pharmacy is trying to reform itself in Australia. We've got a national health insurance scheme called Medicare. It funds doctors and pathology and radiology in hospitals. It doesn't fund pharmacy. That's a separate national insurance scheme called the Pharmaceutical Benefit Scheme, which actually predated Medicare. So we've had a long history of having a comprehensive pharmaceutical insurance scheme, the Pharmaceutical Benefit Scheme. It is run by the Commonwealth Government. It's taxpayer funded, so you don't actually make a contribution for it to be in this. You're in it, as long as you're a resident in the country and the taxes are funding it. Now that could be seen as being inefficient. It covers too many people, or it's not sending good price signals, but it's actually a very equitable system. It covers the cost of pharmaceuticals in a wide range of areas, in every place other than acute care public hospitals. But it's built on top of our TGA, our Therapeutic Goods Administration's evaluation of medicines, making sure they are of appropriate quality, safety and efficacy. What the PBS does is then also check to make sure the medicine is cost effective. Now we actually spend about 14% of our total healthcare budget on pharmaceuticals. So pharmaceuticals is the way we measure. We don't measure pharmacists. If you look at the way our healthcare budget is divided up, they talk about expenditure on doctors and pathology and radiology and hospitals and medicines, not pharmacists or pharmacy, but medicines. So it's a bit of a pity that they express it that way, but 14% spent on medicines. Almost 60% of that is on the PBS, so you can see it's a very significant part of our total medicine expenditure. Where are the other dollars spent? Over-the-counter medicines or the public hospital anaesthetic drugs and drugs in the public hospitals not covered by the PBS. Of that amount that is spent on the PBS, 22.5% is spent on the supply chain. So it's not the cost of the drug itself, it's the cost of moving the drug through the process, the wholesalers and the pharmacists doing the dispensing. And each time a pharmacist dispenses a PBS prescription, they get remunerated on the basis of a markup and a dispensing fee. That 22.5% is about $3 billion a year in Australia. And the government looks at that and says, that is too much. We're spending too much on the pharmacists doing this task. And they will do a lot to try to reduce that level of expenditure. Now, for 25 years, we've been trying to build professional programs where we would be funded not for supply medicine, but for doing other things. So I'm going to show you a long list of those in a second. It's interesting to think that at the moment, the amount of expenditure on professional programs amounts to $134 million a year in Australia. So it's a drop in the bucket compared with the $9.6 billion spent on the PBS, or even if you look at the amount spent on the pharmacists in the program, $2.16 billion, plus the wholesalers, $634 million. The amount we're getting for professional programs at the moment is a drop in the bucket, but it's a very important drop. It's a very, very important. This is the future. This is what we have to build. Why do I get so concerned about the PBS and expenditure in pharmacy in Australia? Because it accounts for the vast majority of the revenue of a pharmacy. 70% of the revenue of pharmacy comes from the supply of prescriptions. So any move by the government through that policy hierarchy that I said previously to squeeze on the payment for prescriptions has a huge impact on pharmacists. You can see that there's another 13% of income that comes from the supply of over-the-counter medicines, or what we call pharmacist-only or pharmacy medicines, and then general retail accounts for a very, very small proportion of the revenue of pharmacy. The other bit of the picture I just need to quickly touch on before I go through the professional programs that we've developed in response to this policy change. Pharmacists, we've got about 22,000 in the workforce. The vast majority work in community pharmacy. 63% work in community pharmacy. So what I'm talking about is not only critical to the businesses of pharmacy, but it's critical to the majority of pharmacists. That's where the majority of us work. Pharmacy is still privately owned in Australia, privately owned by pharmacists. There's no allowance for non-pharmacist corporations to own pharmacies in Australia. So we are limited in the amount of financial support we can bring to bear because it's all got to be private capital. And we are actually restricted in the number of pharmacies we can own. So our capacity to build corporate chains to help address the economic drivers is quite limited. We do find a lot of marketing banner groups, Priceline, Holiday Pharmacy. They are there to help pharmacists share the expertise in marketing, but they're not ownership structures. So, one more point as background. We've had concern about where the profession was going, the difficulties it was facing, and we thought we needed a perspective of what our future should look like. If we actually don't develop that perspective ourselves, the risk is our future will be made for us by somebody else. And so we developed a vision statement. It's a substantial document. I've only picked out here the 10 points that we think are the major functions of pharmacists. These slides will be available to you later, I'm sure, so you'll get those points if you want. But I pointed this out because I'm trying to make sure that you understand we've been trying to approach and address this issue of high dependency on supply of medicines for quite a while. And we've developed a lot of steps to try to make sure that we can broaden our professional activity and include revenue as funding for some of these additional professional services. Like most organisations, we have a range of organisations, a registering authority, our pharmacy board, we've got a professional association, the Pharmaceutical Society, the sister organisation of this one. We've got an organisation, the Pharmacy Guild, which represents the proprietors of pharmacies, a group representing hospital pharmacy, and another group, the Australian Pharmacy Council, with the responsibility for trying to maintain quality within the profession through accreditation of universities and the like. There are a lot more professional associations, and I suspect one of the reasons we've had a lot of difficulty moving things forward is we might actually be speaking with too many voices rather than consolidating behind one organisation. The Pharmaceutical Society, which was the major professional association there, has promulgated a whole range of professional practice standards. And again, if you look at the PSA website, you'll see these. They cover basically all the areas of practice that a pharmacist might be involved with. Now, the Pharmaceutical Society promulgates these. It's the pharmacy board that's responsible for making sure pharmacists are compliant with national guidelines for practice. So these practice standards of the professional society are really voluntary practice standards. I need to go back at this point to about 1989, it's almost 25 years ago, and we found the profession at that stage was facing some difficulty in the way it was being remunerated. And we actually established a relationship between the profession and the federal government, the agency, the level of government that operates the Pharmaceutical Benefit Scheme. And we established for the first time what was called a community pharmacy agreement. It was a 5-year agreement between those two bodies, the profession and the federal government. We've actually perpetuated that concept now for 5 times, and we are in our 5th community pharmacy agreement. And I think there's great merit in this concept of establishing a single point of reference between the profession and the major funding agency, the insurance agency, in our case the Pharmaceutical Benefit Scheme. Because I pointed out a few seconds ago how we've got a long list of many professional organisations, and often they speak with multiple voices. If you are actually going to move things forward, sometimes you need to make sure all of your voices come together and sing from the same songbook, and then the other side, in this case our Pharmaceutical Benefit Scheme, the government, truly understands what the issues are and can work with us. What we did in our first agreement, not only did it actually establish the remuneration for our dispensing activities and the like, it started to apply some constraint or restraint on where pharmacies could be located. That has continued in each of the 5 agreements. Dispensing fees have been agreed, relocation rules for pharmacies have been negotiated. But I want to focus on another side of the agreement. The first agreement had funding for research and development. Until this stage, there had been no specific funding available to do research into pharmacy practice. And here was a bucket of money, and initially it was about $10 million, available in that first 5-year period to study what needs to be done in terms of professional pharmacy practice in community pharmacy to sustain and develop the profession. The funding in this, the funding of that research and development has continued in each agreement. And in each agreement, it's been made available largely to the university-based pharmacists, the academics, to study areas of practice development that was mutually agreed between the profession and the researchers would be a suitable thing to focus on. And what I've got on this slide is a tabulation of how that has evolved. So in the first agreement, and these dates, 1992, that should say to 1995, there was money spent on research and development. During that 5-year period, the most telling area of research was in relation to pharmacists doing medication reviews in residential aged care facilities. So we're talking here about nursing homes, aged care facilities, and the research conducted showed that it was cost effective for the government to fund pharmacists to review patients' medication in aged care facilities. The government would gain financially if it did so. Because that was proven by research in the first agreement, when we got to the second agreement, 1995 to 2000, that was incorporated in the agreement, and we, for the first time, had funding for such a professional program. But as I said, we still had another bucket of research money in the second agreement, and during that second agreement, further research was done in a wide range of areas, but 2 in particular, which are notable. One was that the work that was proven to be cost-effective in residential aged care facilities could also be conducted in people's homes. And so we had consequently introduced in the third agreement, on the basis of research that was conducted in the second, we had the introduction of home medicine reviews. We also had introduced in the third agreement the funding of the distribution of consumer medicines information. Research had been conducted in the previous agreement to come to a decision as to what would constitute a suitable information leaflet, a standardised information leaflet to be made available to people for all medicines on the PBS, and the profession was funded to distribute those to people on an as-needs basis in the third agreement. The third agreement had new money in the R&D bucket, and research in that agreement led to the introduction of a number of other professional programs in the fourth agreement, including things like the provision of dose administration aids, packing medicines into Webster packs or other sachets, individual dosing sachets. So each time we've actually got some money available for research, using that money to prove the cost effectiveness or the credibility of a new professional program, which was then able to be introduced as a funded program in the next agreement. Other things that were introduced into that fourth agreement included the provision of medication profiles. So at that really risky spot where people transition between different carers, between hospital and aged care, or between community ambulatory care and residential aged care, a high risk point where often the comprehensive list of medicines a patient's on is not available to the people caring for the person at the next level of care. We proved the value of pharmacists preparing a medication profile and making it available at that point of transition. In the fourth Community Pharmacy Agreement, 2005 to 2010, the money available in the research and development bucket was used to prove a number of other things, including medicine use review in pharmacies, a scenario where a person would sit down with the pharmacist and review the patient's medication. It's basically a compliance consultation. Stage supply, clinical interventions. I'm going to go through a few of these in a little bit more detail in a minute. So the first lesson here is it takes time. It needs evidence. Gathering the evidence needs funding. Who put the money in the R&D bucket? It was a mutual agreement between the government and the profession. So we both contribute to it because we both stand to benefit. And you can see how you can actually stage the development of the professional programs. I wish it had not taken 25 years to get where we are, but if we'd not had this structure, I doubt we would have got to this point. Let's quickly look at a couple of these professional programs. I'll just reiterate some of the points I've already made. Consumer medicines information leaflets to help people in that transition. You can appreciate how you can prove to the government that if at the point of transition, the doctor caring for the patient who's gone into the hospital has a comprehensive list of their medicines, you can enhance safety. And that will reduce the cost to the government of the subsequent care of the patient. Dose administration aids, whether it's a blister, a sachet, a Webster pack or whatever, they're funded for people in the ambulatory setting. So elderly people, or people who are confused about their medicines, those medicines can be packed into some calendar pack to help them manage their dosing. Why? Because we know that the most common reason for people to be admitted into residential aged care is that they cannot manage their medicines. So this is one way of keeping people in their homes at a much cheaper level of healthcare than seeing them admitted into residential aged care. Stage supply, somebody in ambulatory care who may be at risk if they were to be given a full dispensed quantity of medicine. They may be a person with a severe depression, and there may be a suicidal tendency, and if they were supplied their full quantity, there may be a risk of harm. And so pharmacists can be funded to supply those medicines to the patient in daily or weekly quantities. So the patient is maintained on their care, but you reduce the risk of self-harm with large quantities of medicine. I wanted to look at these in a little bit more detail because this is where we're starting to see the pharmacist emerge as a true professional away from, but not dependent upon the supply of medication. Most of those others were still related to the supply function. And I've already tried to explain how reliant on supply can be a real problem for us. This is a range of developments that eventually leads to the pharmacist being independent of the supply function and purely focused on a professional role of ensuring best use of medicines. I'll start with the second one, the medicine use review. In Australia, we call this Meds Check. I don't know why we had to come up with a particular name for it. Everybody else around the world calls it a medicine use review. It's an in-pharmacy review of the patient's medicine focused on identifying medicine-related compliance issues. So, as I said, it's about compliance. Each time somebody was dispensed medicine, they should have been counselled about the appropriate use of that medicine. But of course, people often have multiple medicines, not all of which are dispensed at the same time. So this is an opportunity for a pharmacist to sit down with a person, be funded by the federal government through the Pharmaceutical Benefits Insurance Scheme, to sit down with the patient and go through their full range of medicines in the pharmacy. The next step is the home medicine review. This isn't a compliance review, this is much more detailed. For this to be undertaken, the pharmacist needs to be credentialed. Every pharmacist is expected to be able to undertake a medicines use review in a pharmacy. It should be part of your your core skills. But to do a home medicine review, to work on the basis of a referral from a GP and to go into a person's home and conduct a clinical review of the use of the medicine, ensure that it's appropriate for the diagnosis and to ensure the patient has good understanding of the risks and benefits of the use of the medication. The pharmacist has to be credentialed. They have to work on a referral from a doctor. They have to prepare a report that goes back to the doctor, and there's to be a case conference, part of that collaborative care between the doctor and the patient and the pharmacist. The residential medication management review, and it's interesting, it's at the bottom of the list, and this was the first of this range of programs that we introduced. That's the service undertaken in an aged care facility. Put this one up just to try and put some of these new services into the spectrum of services that are likely to be delivered in primary care by pharmacists. Down the bottom, dispensing and supply medicines. It is, and will always remain, the core function of pharmacists. Provision of information and advice. We have, from the Pharmaceutical Society in Australia, a concept called self-care, which is a package available to pharmacists to help them deliver information and advice to people. Above that, triage to other health workers. This is the other entry point for people into the health system that I said was an outcome of the comprehensive range of reviews of the health system in Australia. Rather than everybody trying to enter the health system through their GP, pharmacists can provide this service. We have been providing this service. The trouble is, it's not been documented, and we've not gained the recognition for it. But as you know, people will come into pharmacies with a sprain or some jaw ache, and we make decisions about whether they should see their physiotherapist or go to their dentist. We provide some basic minor ailment treatments, but we also make referrals or triage those people into other parts of the health system. We have to document that. We have to make that really clear. Why we're doing it, who's benefiting from that. Further up the list, we've got health promotion and prevention, we've got screening and monitoring, and then we're getting up to the medication reviews that I was just describing in the previous slide. Right up the top, collaborative disease management. Sometimes these steps are referred to by different names in different countries. I will introduce that concept here. I'm looking at the same work that I've just been describing, but in a slightly different way. The concept of a patient enters the system with a prescription. It's a new prescription. It's dispensed for them in the pharmacy. They would receive some counselling in relation to that medicine. They would be provided a consumer medicines information leaflet, one of those concepts that was introduced during our program. They might receive a device if it's a spacer for their puffer or something like that. If it's chronic therapy, in our system, the prescriber can write a prescription for roughly a month's therapy and up to 5 repeats. So they come back in a month's time, see the pharmacist again, the repeat prescription is dispensed. It's an opportunity to check adherence. Are they compliant with that medicine? I mean, if they actually have a month's supply and they come back in 6 weeks or 8 weeks, it's an ideal opportunity to say, well, what do you understand about your dosage, how are you using it, and determine whether they are compliant or non-compliant, what the reason might be, and whether they might benefit from a dose administration aid, like a Webster pack, and be funded to provide that to the person if they satisfy the necessary criteria. Eventually there might be a need for a clinical intervention of some description. You might refer them to their GP. If there's a real problem with compliance, refer them back to their GP. Or eventually, you may well, if the person satisfies the criteria, such as having a certain number of medicines or being certain trigger medicines in their range of medicines, you might offer them a meds check in the pharmacy, sitting down with them, a consultation, roughly 20 minutes, for which we get funded 60 Australian dollars, and undertake a meds check. What might come out of that meds check is a referral back to their GP or a recommendation that they actually have a medication review at home. Because in the pharmacy doing a meds check, you do not necessarily get the whole picture. You can't see what they've got in the cupboards at home, and you can't see the conditions under which they're storing their medicines. So there might be a referral to do a medication review, be it in their home or at this stage in an aged care facility. Up the top is the next step, which we really have yet to introduce in Australia, but it's recognising a higher level of professional and clinical participation by the pharmacist. It's helping with the management of medication in chronic disease. So we're talking about patients who are long-term users of medication, and the opportunity for pharmacists to take a greater role in decision-making around the re-prescribing or the ordering of pathology tests. And so that's where this whole sequence of medication management goes to. And then you can see, as we move from left to right, it's an increasing level of complexity and patient need, but it's also an increasing level of pharmacists' knowledge and skills and a greater need for credentialing or higher qualification. Wide range of other professional services that have been introduced in Australia, completely aside from the pharmaceutical benefit scheme and the professional programs in that scheme through community pharmacy agreements. Supplying pharmacist-only medicines, opioid substitution with methadone, buprenorphine, return of unwanted medicines, the yellow bins there are distributed free of charge by our wholesalers to any pharmacy, so that any time somebody has expired or excessive medicine that they don't need, rather than it going into waste, into landfill, into the sewage system, it can be taken back to a pharmacy, put into one of these bins, which we eventually collected by the wholesalers again, and taken for high temperature incineration. So it's a huge public health benefit, making sure that excess wasted expired medicines do not contaminate the environment. Again, it's an unrecognised service that pharmacy delivers to the community. So there's a wide range of other professional services that are delivered, and I come back to this slide. Our objective is to build funding for these services completely aside from the funding that we receive for supply, in recognition that the insurers of the supplied medicines will continue to work to squeeze the revenue base there. They will naturally do that, and we have to understand it, and as taxpayers completely support that concept. So just to sum up, how does this all tie together? I've shown you most of these factors in the presentation. In the centre, we've got the notion that pharmacists must make transition from transaction-based, commoditised model of practice, in other words, focusing just on the product, to a relationship-based, consumer-centric and collaborative model of care. How are we pushing for that? We're using standards of practice, which I've illustrated up here on the top left, delivered by the Pharmaceutical Society as the professional body. We've got the Pharmacy Guild as representing the proprietors who own the pharmacies, ensuring quality by running a quality care program that I didn't mention previously, but that's an aspect that is partly funded through our community pharmacy agreements. We've got the Pharmacy Board and the Australian Pharmacy Council ensuring compliance and making sure that standards are met through the accreditation processes and the registration of practitioners. And over on the right, we've got the PBS funding medicines, but hopefully with a growing amount of payment for professional services. So that's a quick tour of how global policies have evolved that will eventually, starting with policies around universal health coverage, making medical care, including pharmaceuticals, more available to people at a cost that they can afford, stepping down through policies that assure the quality of the products, down to policies that address how we ourselves as pharmacists will help to deliver them. And hopefully what you've seen from our practice in Australia over the long history of the community pharmacy agreements, which now I think are starting to deliver some quite significant professional services that pharmacists can find rewarding, not just rewarding commercially, but definitely rewarding professionally. All of that has grown up, and hopefully that's been of some value to you and will help you perhaps set the course of your profession in Fiji. Thank you.
And finished with time to spare, actually. Okay. So thank you, Mr. John Jackson. I'm really surprised that he managed to memorize all of that information. I mean, I wouldn't be able to. And I'm half his age.